Good morning, everybody. Welcome to the Hopkins Bloomberg Center. It is a privilege and honor to welcome you all here today. I'm Laura Sigmund, the director of the Strategic Solutions team at the Armstrong Institute for Patient Safety and Quality at Johns Hopkins Medicine, and honored to be the chair of this event. On behalf of my colleagues at the Armstrong Institute and our partners from Patients for Patient Safety US, we're honored that each of you took time out of your busy schedules to be here. Thank you. As all of us know, many of the issues we face in patient safety and healthcare quality have remained stubbornly unchanged for decades. Despite extensive research, new policies and measures, and tireless work on healthcare's front lines, harm still happens all too often. Our vision for today is to collaborate across disciplines and perspectives to develop bold, actionable ideas that can be implemented. Building on what we already know, which we'll get introductions for, how do we bridge policy, research, and practice to make things better in the future? This symposium is an invitation and a challenge to innovate. As the saying goes, there is no growth in the comfort zone. While I very much hope that all of you will enjoy the beautiful setting here at the Bloomberg Center and reconnecting with people you know well, I also hope that we will use today to work with new people, challenge assumptions, listen deeply, and co-create actionable strategies that translate knowledge into practice, even and especially if it means thinking differently and leaving the familiarity of our comfort zones. I'd like to extend my deepest thanks to the Doris Duke Foundation and its partners through the Collective to Strengthen Pathways for Health Research for their generous support of today's work. Dr. Cindy Escobar Alvarez, the Foundation's Program Director for Medical Research, will speak to you shortly about the vision and objectives behind their sponsorship. I also want to acknowledge some of the many people who have devoted their time and energy to make today happen. An outstanding group of individuals quickly conceptualized and implemented the details for today's event. They did so with dedication, creativity, and flexibility. Vanessa Llewellyn, Io McClenny, Brian Konashevitz, and Anna Korbel from my team, Marty Hatley, the co-chair for this event from Patients for Patient Safety US, and his colleagues with Patients for Patient Safety US, and our steering committee, Alan Kachalia, Angela Green, Kathy McDonald, Peter Najjar, and David Newman-Toker. I feel fortunate that we have a very talented group of facilitators and co-facilitators who jumped in to lead the work groups today. Allison Perry, our head facilitator and an accomplished leader in patient safety and healthcare innovation, will introduce the team shortly. Many others from Armstrong and the Bloomberg Center have helped make this symposium possible. Thanks to each of you. I will now turn it over to Dr. Alan Kachalia, the director of the Armstrong Institute and Senior Vice President for Patient Safety and Quality at Johns Hopkins Medicine. And then we will move on to Carol Hemmelgarn, a founding member of Patients for Patient Safety US and Program Director for the Executive Master's Program in Clinical Quality, Safety, and Leadership at Georgetown University. We are particularly lucky to have Carol here today, as it is also her program's graduation at Georgetown across town. So thank you all. At that, I will hand it over to Alan.
Well, good morning, everyone. I'm going to keep my comments really brief. It's just absolutely thrilling and exciting to be here. So, on behalf of Armstrong, as Laura mentioned, and our partner, the Patients for Patient Safety, I just want to thank everybody for being here. I know how busy a time this is for so many of us. And the fact that you can make time to be here for us to advocate on our common goal of improving safety and quality for our patients means a lot. As Laura mentioned, a special thanks to the Doris Duke Foundation for hosting these conversations. My understanding there's about 16 or 17 of them across the country, and we're just happy to be a host and proud to be a host here. And again, their goal really is on improving outcomes by helping us figure out how do we take what we've learned in research and get it into practice. What's the best way to make that happen? And again, a special thanks to the Doris Duke Foundation on that. And a moment to thank Laura. For those of you that have watched the team from behind the scenes work to put this together and to communicate with everybody, it's no small feat. And that's why I'm smiling so much, because it's just a lovely group of people that's been put together here. And so far, everything's been going super smoothly. And Laura, I know it's a thank you for this, and Marty too. Thank you so much for your leadership on this. And I know it's a team effort, as you'd mentioned. You know, a special thanks to Brian, Vanessa, Io, and Anna too for helping this come along. Can we just take a moment to thank them, if that's okay? And, you know, just a few words on today. As I mentioned earlier, it's just, the other reason I'm smiling is that there's so many familiar faces in this room and people I've had the privilege of knowing for many years. And I know that many of us have been working on how do we improve quality and safety for our patients in healthcare for a number of years. And I think many of us share the same sentiment that progress really hasn't been as fast as we'd hoped. But that said, I think many of us would agree there's been a lot of progress. The fact that we have meetings like this, the fact that we don't have to argue that improving outcomes is important anymore is a lot of progress. And you know, that's why we're here today, is to how do we figure out how we accelerate this change that we have all started. Our goal in this meeting is relatively straightforward, right? We want to gather everybody's voices, everybody's ideas and opinions towards how do we build a blueprint for progress in the future here. We all know there's power in numbers, and many of us have been working independently. Our hope is how do we come together to bring all this expertise we have as well to shape a strong and uniform message about how important quality and safety is to get it right, and how we can come together and put these ideas out there to drive this forward. And again, I want to remind everybody, it's really about improving outcomes and how do we translate everything that we know and put it into practice. Our big ask, as Laura alluded to earlier, is that everybody speaks freely today. And how do we think about challenging and improving upon the status quo? And just a couple side notes. I know that many of us, especially those of us who work in academic organizations, and this includes me, are worried about how much research funding we're going to be seeing in the future. Now, I'm not going to argue that's not an important point, it is. But I think our focus today is how do we translate everything that we learn from research and everything that we know into practice. My hope is that as we can show people that what we take from research, show how it improves care, that also builds the case for research along the way as we go too. So I just wanted to put that out there too. Again, there's a lot to talk about today. And again, I want to thank our partners, our funders, and you all for joining us. I look forward to catching up with so many of you and learning about the incredible ideas that I'm sure we're sure to hear about. So thank you again for being here today. Really appreciate it.
Silence. It makes us feel uncomfortable. And I want you to feel uncomfortable today. Your mission, should you choose to accept it, is to think differently about patient safety. Let's forget about what we've done in the past, and let's dream about what we can do in the future. What I want you to do today is to be innovative, creative, bold, but most importantly, vulnerable with your thoughts, concepts, and ideas. I want you to listen, but truly hear your colleagues and what they're saying. Be curious, be reflective, and build upon it with yes and not but. We need to feel that cognitive dissonance today. We need to reshape our beliefs and attitudes and figure out how we move forward in patient safety. I don't know what's going to happen today, but I do know that patient safety is in a state of flux. Maybe our being here today is a way to come together and have a united voice around patient safety. Maybe today, the Doris Duke Foundation is the next iteration of the Annenberg Conference. Maybe today, we walk away with one or two bold, new, innovative ideas for diagnostic excellence, system design, or patient engagement. I can tell you, though, 3 things I do know. 1, harm is still happening every day to patients and families, and lives are being lost. The second thing is, we have not progressed quick enough and with as much change since the IOM to Errors Human report came out 25 years ago. And the third thing is, we can't do this work without engaging patients and families. You see, this work that we do happens to and for patients and families, but it really should happen by and with patients and families. It's about co-creation because everything we do impacts them. So I'm going to leave you with this one thought. The future belongs to those who have beautiful dreams. And to predict the future, we must invent it. Thank you.
Thank you so much, Carol. I'm now going to invite Dr. Cindy Escobar-Alvarez from the Doris Duke Foundation to give us some words about the collective that has been established to fund this symposium and 18 others that are happening across the country. Thank you for being here.
And thank you so much for those words. What a way to start. Thank you for that invitation. So good morning. I am the director for the Medical Research Program at the Doris Duke Foundation. And first, just want to thank the team who organized this day. It is and for giving us 10 minutes, less than 10 minutes. I'll say it in less than 10 minutes, but for giving us a little bit of time to really share why the 10-member collective to strengthen pathways for health research partnered with 18 organizations across the country to host conversations like today's over the next 4 months. So this is, we hope, a burst of discussion and exchange and reimagination as we were invited and heard just a few minutes from our 3 previous speakers. Thank you for the Institute and its partnership, to the team, to Dr. Laura Siegman for your leadership, and for the team that was involved in making today possible. At the Doris Duke Foundation, we are building a more creative, equitable, and sustainable future through support for initiatives in arts and culture, nature, and health and well-being. And our initiatives are rooted in long-term impact. We invest in big ideas that change the fields we work in the long term. And as it relates to health, the Foundation's longstanding support for medical research has sharpened our appreciation for the breadth of research approaches and abilities that are needed to turn knowledge into healthy lives. To further health, we need to understand the basic functioning of cells, how these processes are altered, how they work, how these processes are altered in disease states, and how these cells and processes exist as part of organs, as humans, and as humans as whole organisms. And how humans interact with their environment in health and disease. Yet our system of scientific innovation has often dichotomized this spectrum of research into basic and applied, really doing us a disservice and creating a tension that it is one or the other that deserves more attention and more investment. And that some are more valuable than others. We often see that. So at the Doris Duke Foundation, we believe that we need different types of knowledge to inform how to improve health. And that there is an undertapped frontier of innovation that you have all been advancing for so long, where there are more opportunities to advance health research and disease prevention, as well as an improvement of healthcare delivery. So together with the American Cancer Society, the American Heart Association, the Boris Wellcome Fund, the Conrad Prebys Foundation, the Dana Foundation, the Donahue Foundation, the Robertson Foundation, Susan G. Komen, and an anonymous foundation, we set out to elevate the voices and ideas that are offering opportunity to improve health in a different way than has been familiar to those investing in drug discovery, for example. We will document these ideas that are raised throughout the 18 conversations and share them widely. And as the scientific enterprise is forcefully reconfigured, as we were reminded, these conversations are as timely and relevant as when the collective set out to support them last year. We are particularly interested in learning three things. The first one is, how can these research questions be better supported and moved into application? Second is, what is the analogous pipeline to drug delivery, and how could it be made clearer and easier to navigate for contributing researchers and investors? And third is, who are the different stakeholders and investors who can support knowledge generation and, importantly, its application? There's certainly great uncertainty, but the future is not inevitable. And we have an unprecedented opportunity to shape how research could be funded differently, and how it could be more inclusive of this new frontier. Not new frontier, but this rich frontier, I guess I would correct myself. And to let go for traditional models and to really challenge ourselves to think differently. Thank you in advance, for all that will be shared as part of this program. I'm just grateful to be here.
Thank you so much. Next, I have the pleasure to call up Allison Perry, our head facilitator for the day, and she will go through the plan for the day, some guidelines, and overall structure. Welcome, Allison.
Good morning. I'm short, so hopefully you can see me over the podium. So many familiar faces. I've already given a lot of hugs today. I look forward to meeting those of you that I don't know. Just thrilled to be here. I am Allison Perry, and I am the head facilitator for today, for today's workshop. I'm also joined by a very talented group of facilitators: Karen Baldoza, Lorenzo Nicholson, Steve Carpenter, Erica Reinhart, Melissa Parkerton, Wilson Lammy, Cindy Dwyer, and Ray Terhorst. If you all could just raise your hand and say hello to everybody. We will all be here to walk you through this process that's been set out before all of us. You'll notice a colored dot on your name badge. That's your workshop room assignment, and facilitators have a yellow dot along with staff, so please don't hesitate to find any one of us. If you have any questions, we're happy to help. So today, what are we doing today? Well, you heard the broad vision for today, but now I'm going to get into a little bit more of the specifics. So today's workshop is designed to generate ideas. Maybe it's ideas you came with, maybe it's ideas that you come up with throughout the day. It's about shaping a shared vision for safer, higher quality healthcare and identifying 3 to 5 strategic actions to reduce preventable harm and improve health outcomes. Together, we'll focus our attention on one of 3 key domains: diagnostic excellence, patient experience, or system design. Over the next 40 to 50 minutes, we'll set the stage for this important work. First, I'll introduce a few shared norms to guide you through how we will work together today. Then I will invite you into a short reflection to spark your imagination. And finally, you'll hear from 3 scene setters who will provide insight, urgency, and vision across each of our focused areas. After that, we'll head upstairs to the 9th floor to breakout rooms to begin designing our blueprint for action. So let's talk a little bit about norms. We're gonna just set the tone here a little bit, and because today's work is highly interactive, very collaborative, it's important that we create an environment where everyone feels safe, heard, and valued. And I'm sure you all agree that that's your intent as well too. So here are a few guiding norms to help us do that. Listen generously. Make space for each other to be heard. That means resisting the urge to interrupt, and it also means resist the urge to mentally prepare your response while someone is talking. So actually listen. Speak openly and honestly. Your voice matters. Share your stories, your perspectives, your questions. This is a space for co-creation, not perfection. I know that's really hard for probably all of us in the room. And then mix it up. So as Alan said, as I mentioned as I started, we all are joining friends that maybe we haven't seen in a while. When you get to your work group, we invite you to sit with someone you don't know. New connections often lead to the most unexpected and meaningful insights. Now, we understand how busy you all are and that work back home hasn't stopped. We do ask that if you need to take a call or respond to work email, that you please step out into any of the lounge areas on the 9th floor. You can go to another floor if needed, so that we can maintain a shared focus in the room. We are also meeting at a time of profound challenge. Rapid change in healthcare. It's easy and it's human to get pulled into the frustration or politics of the moment. But today we ask you to stay focused in what we can shape, a bold, actionable, and collective vision for the future. So you might see us holding up a sign that says, "Focus on the future." That's our gentle cue. It's available to everyone in the room to use, to redirect our energy towards the aspirational and what is possible. Please feel free to use it too with care and kindness. And finally, have fun. This is a day for connection, for curiosity, for creativity. So whether you are reconnecting with familiar colleagues or meeting new ones, we hope you'll bring your whole self to the experience. Okay, before we dive in, let's do a little time travel. I invite you to first look back. Where were you in May of 2015? Maybe you were starting a new role, celebrating a milestone, navigating a big decision. Whatever it was, place yourself in that moment. Now ask yourself, what do you wish you had known then? This could be personal, could be work. What action might you have taken earlier with the benefit of hindsight? Man, I wish I bought more Bitcoin. Now let's look ahead. Imagine it is May of 2035. What's different in healthcare? Every patient leaves a medical visit with a diagnosis they fully understand. Medical devices are designed with safety as a foundational principle. Harm isn't just reduced, it's unimaginable. What's your bold vision? What would you love to say we accomplished over the next decade? Now come a little closer to the present. What could we achieve in 2 to 3 years? What could move us toward that future? In our workshop sessions, we'll be working through that question, identifying actionable strategies across 4 domains of intervention. They will include development of AI and advanced technologies, operational implementation of best practices, policy and oversight, financial incentives, including reimagined funding models, reimbursement, or other financial levers that drive adoption and sustainability of good practices. To help us launch into that work, we've invited 3 remarkable contributors to serve as today's scene setters: David Newman-Toker, Marty Hatley, and Aisha Gerses. Each will speak to one of our key themes: diagnostic excellence, patient experience, and system design, offering clarity about where we are today and insight into what's possible tomorrow. Let's welcome our first scene setter, Dr. David Newman-Toker.
Thanks, Allison, and thank you to the Doris Duke Foundation, as well as our partners, Patients for Patient Safety, and everyone on the Hopkins team that's been involved in this process. I am the first scene setter today, and hopefully I haven't bitten off more than I can chew in the 10 minutes that I've been given. I've called this the road less traveled by, paving a path towards diagnostic excellence, and hopefully this will get us all up to speed to where we can have productive conversations in our breakout sessions. I'm going to start with a case, and this is the tragic story of John Michael Knight's misdiagnosis. This is a real patient, and he and his family have given me permission to share his story so that this will never happen to anyone else again. At the time, he was an 18-year-old star lacrosse player. He developed vertigo, vomiting, and unsteady walking 2 days after his final high school game. His parents were very worried. They took him to the emergency department, said he's never sick, he's like an Iron Man. Doctors, they felt like the doctors really weren't listening to what they were saying, and they were sure this was something serious, but the doctors weren't. They were focused on drug abuse, which I suppose happens in teenagers, and they were focused on inner ear problems, but that wasn't what was going on. And unfortunately, they didn't consider a key dangerous cause or the red flags of what that is, and what he had was an evolving brainstem stroke, which unfortunately, because the time window had passed for treating him, left him locked in. For those who don't know, that means he's mute and quadriplegic, but he's totally cognitively intact. He has to communicate by blinking his eyelids, and he's painstakingly recovered over the years to where he can tip his head enough to operate a motorized wheelchair. This is a tragedy. It's a tragedy for everyone. It's a tragedy for him, for his family, for the doctors, for the hospital, for the healthcare system, for society, for the economy. And it doesn't take too many cases like this before it starts to add up. This is what could have been. He was going to college on a full athletic and academic scholarship, and had he been diagnosed promptly by methods that we've described for the last 15 or 20 years, by looking carefully at his eye movements at the bedside, he could have gotten prompt clot-busting drugs. He might have even been saved by a 1-penny aspirin, and he would probably be done with college and playing an active role in society now. Instead, he has to continue to fight for his existence in the state that he's in. So I'm going to break my remarks up into 2 sections. One, where we've been, and then where we're headed. I'll go quickly through the where we've been, to the road so far, the burden of diagnostic errors, top targets that we might focus on, and common underlying causes. And then I'm going to just spend a couple minutes setting the stage for discussions later today, talking about artificial intelligence, what I call the 4 Ts, and some policy recommendations. So, where we've been. Many of you in this room are friends and colleagues that have been part of this journey, and this will be familiar to you. But really, diagnostic excellence started early in the game, in the mid-aughts, and I apologize, some of the fonts may have not translated across computers. The Diagnostic Error in Medicine meeting was formed, the Society to Improve Diagnosis in Medicine, in 2011. The National Academy of Medicine report, which was sparked by this group in 2015, was a real landmark that started bringing others into the field, including the Gordon and Betty Moore Foundation, with significant contributions to the research in the field. We had appropriations authorizing legislation being put into both the House and the Senate, grants through ARC, a quality improvement program through the Society of Improved Diagnosis in Medicine. Then by 2022, we had centers of excellence around the country. Many of these things were things that we had laid out 10 years earlier as visions for what would happen, and they came to fruition. We also had big reports on the burden of diagnostic error in the emergency department and across the US. Unfortunately, in this process, we lost CITM, but in the process, we gained Codex and the community to improve diagnosis in medicine, and hopefully there will be a lot more in our future. But I do think we're on an escalating curve here. Diagnostic errors dwarf all other medical errors as far as we can tell. In the USA alone, there are probably 50 to 100 million diagnostic errors each year, somewhere close to 1 million patients who die or are permanently disabled each year at a societal cost of over $200 billion with a B, waste in the range of 50 to 100 billion per year. These are the most common, most catastrophic, and most costly of medical errors. They truly are the bottom of the iceberg of patient safety. It's easy to get bewildered in this space because there are so many different diagnostic errors. What we've done is we've tried to focus people's attention on what we call the big three: vascular events, infections, and cancers. And in these three big buckets, we've shown that the literature, both the malpractice literature and the clinical literature on diagnostic errors, suggests that about 3/4 of all serious harms are due to diseases in these three big buckets. These are the top 5 from each of the big 3 categories. These 15 diseases alone account for about 50% of the serious harms at a population level. And just 5 diseases account for about 39%. And I put this in front of you mainly to point out that we could make a lot of progress by doing a relatively small number of things to fix these problems that are in front of us in terms of preventing serious harms. These aren't the only harms in healthcare related to misdiagnosis, but the most serious of the harms are ones that we could tackle just by focusing on a few key conditions that are causing a lot of that harm. So what causes diagnostic errors? Well, there's a long litany of things, but at the end of the day, the thing that always shows up on the top of the list is clinical judgment or cognitive error, and we will never solve this problem if we don't tackle that. It doesn't mean that there aren't other problems that have to be solved, but we have to solve that one if we're actually going to fix this. Otherwise, it's just not going to happen. And it doesn't matter what condition we're talking about. These are from malpractice data, but they look the same for clinical studies as well. This is from some of the work that Dana Siegel and I did a number of years ago. The bottom line on causes is that most diagnostic errors happen at the bedside. The subtlety of presentations is important, like John Michael Knight presenting with dizziness as opposed to weakness on one side of the body and inability to speak. And the solutions really need to be problem and context specific. There's a high degree of domain specificity, clinical domain specificity in diagnostic errors, and it is super hard to solve these problems with sort of general cross-cutting solutions. Where are we headed? Well, we're going to talk a lot, I'm sure, today about AI. It's hard to have any conference without talking about AI. I spent a little time with ChatGPT yesterday making some pictures. It's interesting what it did well and what it did badly, but this is close to what I was after. And really, we got to decide whether we're going to let the AI that we have win or we're going to go for the AI that we want. But if we're going to have the AI that we want, we're going to need data, because that's really the key problem. So this is one of the studies that showed that biased AI makes physician diagnostic accuracy worse. On the left, that's the AI we're going to get if we're not careful. And then machine language trained on diagnostic outcomes can reduce misses. That's the AI that we want, but it's going to take some work and effort, and that's part of the effort that this group has to do. I'm going to take a moment to talk a little bit about the success story for stroke that we've been pushing for the last 2 decades. And what I call the 4 T's to transform diagnosis: teamwork, training, technology, and tuning. This is a wraparound set of solutions for one known clinical problem. And I do believe there are no magic bullets in this space. We're going to have to surround problems with multiple solution sets. multifaceted solutions like this. We've shown that by simply consulting with people who are experts in the kind of clinical presentations that John Michael Knight has, we can increase the rate of stroke diagnosis compared to a control population by 25-fold, with 97% less waste on unnecessary neuroimaging. With virtual patient training, 9 hours of simulation training we showed was better than 2 years of internal medicine residency for diagnosing this particular problem. And we've been working on smartphone-based solutions that are already on their way to being in people's homes. At the same time, we need to measure our success, and we've developed metrics and methods for doing that, dashboards, and the national quality measure that was recently endorsed related to stroke and dizziness. So, what are the pearls for where we're headed? Stop arguing about exactly how many errors or harms. It's a lot. Focus on what patients care about most, outcomes, especially harms. Emphasize fixing diagnostic failures that happen at the bedside. Accept that there are no magic bullets. Use multifaceted approaches. Remember that if we want AI to work well, it's all about the data. Commit to solving high-harm problems and measure success, and that little star is there about this idea that we need shining star examples. We need to advocate for diagnostic excellence at every possible turn. So, what do I think we need to do? And these are up for debate all day. I'm sure they will be debated. I think we need moonshot-type research funding, at least equivalent to the healthcare-associated infections world. We need to invest in gold standard data sets to support AI-based scaling, and we need to deploy the initiatives that we have developed via policy initiatives that include funding for large comparative effectiveness trials, deploying quality metrics and oversight, and symptom-based payment models that actually support better diagnosis. So I made it 5 years because 2 to 3 seemed short to me, but was to have 3 shining star examples in the next 5 years as successes. One of them might be stroke. And in 10 years, I think we can cut by 250,000 the number of people who die or permanently disabled by diagnostic error. And I'll just close with I was asked to give a provocative question. This is the genie in a bottle challenge question. So this is the famous quote from Deming: every system is perfectly designed to get the results that it gets. And ours is not getting great results right now, with 1 million people maimed and killed each year. So now a genie has dropped in, and they've appeared. They can grant you 3 wishes related to changing the U.S. healthcare system. With a snap of a finger, genie can fix anything you want: culture, structure, process, overcome any political barriers or logistical problems. How would you re-engineer healthcare to achieve diagnostic excellence outcomes, and what is your bold vision for the future of diagnostic excellence? And with that, I'll close just with one of my favorite quotes in the world: never doubt that a small group of thoughtful, committed, organized citizens can change the world. Indeed, it is the only thing that ever has, and this is what we're here for today. Thank you.
Hi, everybody. I'm Marty Hatley. I'm an organizer of this event. I also want to thank you for coming. I'll especially thank the people who are coming from out of town. I think I've got to get in front of the mic here, because I know travel dollars are tight for many of our organizations. So there were many more people who wanted to come today that just didn't have the travel dollars. And I hope that changes, because we really need a robust community working on this, as David has just mentioned. So I'm scene setting on the patient safety experience. I also want to start by talking about another conference, and it's been mentioned already. This is the Annenberg Conference that happened in October of 1996. I worked for the AMA at the time. This was a conference put together by the AMA and the Joint Commission to assure the American public that we were really paying attention to patient safety. We were using talking points like 99% of the patients in the United States are safe when they go into the healthcare system. At that conference, I wanted Lucian Leap to speak. He didn't think highly of our rhetoric, our public messaging. He insisted that I invite James Reason, the guru of human error. James Reason, and fly him first class from the UK to come to this conference in California. So I did that. He arrived a day early. We had dinner. He said, essentially, I've been waiting for your phone call for 20 years. It's embarrassing for you to think about that 1% as a good record. Do you know how many millions of people that is? But by the way, we understand that you have the hardest job in the world. There is no other human activity that is as complex and as dynamic as healthcare. Constant change, multiple ways that things can go wrong, a lot of variation that you have to manage in patients. So we're here to help. And that was a kickoff. We also had an offer from a liability insurance company who came to us and said, we have a story that we'd like to tell because we promised our client that we would. And it was a hospital in Florida that had a death of a young boy, Ben Kolb. He was in first grade. The death happened over the vacation, his Christmas vacation. He had elective surgery to remove some scar tissue from his ears that had been there from tubes as a little boy. On the sterile field, there were 2 identical cups that had different medications in them. One was lidocaine, the other one was epinephrine. The epinephrine was meant to lace the lidocaine. They gave Ben pure epinephrine. And when he went into heart failure, or the beginning of heart failure, they diagnosed an allergy because he'd never had surgery before. They didn't realize they'd given him this concentrated method. And they fought for his life for 3 hours and lost that battle. But then something beautiful happened. When they did their investigation, the leadership of that organization said, oh my God, I'm sure this has happened somewhere else before, but we just didn't know about it because we don't talk about those things in healthcare. And so we have an obligation to tell the world about what happened to Ben Kolb. And they came to us through their liability insurer, and we gave them a stage. That earned us nationwide coverage in the press, including a New York Times Sunday Magazine cover story a few months later. And there's a through line from that conference to the IOM report, to the work that AHRQ has been doing for years, to the work that many of you have been doing for years, to, I think, this moment, this conference, for us to reinvigorate, as Carol called upon us to do, our commitment to to preserving death, preventing death. Patients for Patient Safety, I'm the Director of Advocacy and Policy for us. I was asked to put out a vision for a goal. Ours is zero harm. We're in that tribe of people that think that any other goal is just not enough to aspire to, even though we know it's a perfect thing that we will never achieve. We do that by patient and family engagement. We think that creates the urgency. You heard Carol speak today, you heard David's story. There's an urgency about these stories because death does matter. Transparency shines a light. When we look at our failures, they are our treasure. We can improve from them. We partner with organizations that want patient and family input into your improvement projects or your research projects or your demonstration projects. And on the accountability and oversight piece, we're really trying to coordinate information, data that anyone can use in an oversight role. We're particularly fond of the idea of a National Patient Safety Board. I know Jewish Healthcare Foundation, Robert Ferguson is in the audience today. We've been supporters of that effort because it's a beautiful thing. It would be low regulation, recommendations, data crunching, patient reports, all funneling out to recommendations to everyone or anyone who has an opportunity to improve safety in the healthcare system. This is a framework I want to, it's not published yet. We did it for WHO, and by we, I mean Sue Sheridan, one of our colleagues, Heather Sherman, recently of HRQ, and me. And this is what we think patient and family engagement is, three domains. We partner at the point of care to get the best outcomes we can get for ourselves and the people that we love. We feed back our experience, this is the blue box, as co-creators of solutions with researchers and with people that are developing tools and knowledge. And the third thing is advocacy. We can go out there and say things that you can't. Right now we are on the Hill arguing for the preservation of funding for diagnostic safety in the federal budget. So wish us luck on that. I think it's a really important thing. We are committed to helping you in our advocacy voice as well. My provocative question is this: shouldn't we be learning more from death? I mean, it is not okay for us to have, let our commitment to patient safety drift. And there's been progress over the last 30 years. I know that. I'm grateful for it. I'm appreciative of it. But there's also been drift. And there are competing priorities that involve money, loss of reputation, liability concerns. That should not trump our commitment to really preventing death and the other harms that come from unsafe care. Oh, we went a slide too early. So this is my provocative question that's supposed to get you thinking today. What can we do to really recommit to preventing harm? And if we're not committed to that, then there's something in our moral compass that needs to be readjusted in the right direction. We have models. Just a quick comparison between the UK and the USA. They have a systemic initiative, several, that are coordinated to try to prevent and learn from death. They have a program there called Learning from Death, where they focus on investigations that can be spread, just the way in which the hospital in Florida where Ben Kolb died, which, by the way, was Martin Memorial. We should call them out because they did the right thing. They have a medical examiner model that involves sitting down with patients and families before the cause of death is finalized to really get the input of patients and families about the things that they see. We don't really do that very well here. The duty of open and honest communication there is a legal duty, not just a professional or ethical duty. It's in the standard of care. We don't have that here. And they have a national transportation safety type board there that's already in its second iteration. It wasn't perfect. It needed improvement. And our bill is still languishing. I mean, it has bipartisan support, but it just doesn't really have momentum. Our death statistics are really driven by death certificates, and there is no field there for unsafe care. So the default is natural causes. We believe that most deaths where there's a contributing factor of unsafe care come across or get counted as natural causes. Although I am sympathetic with what David just said too about let's quit arguing about the number and just realize that there's a lot. What do patients and families bring to the equation? I wanted to share a couple of studies. The BARDISH study was a little demonstration project in California where they trained patients and families about what the incident reporting system in that setting was looking for. And then they gave them an app to report it. The patients over the course of the project reported 51 incidents that qualified for incident reporting. How many were reported by the system itself? Tejal, I know you're in the audience. Oh, I saw 0 over there. Tejal, I actually heard about this study first in a presentation that you gave. So the number was 1. There was 1 that came through the reporting system and 51 that came from patients and families. So we know patients and families are really eager to report, and they will do it if we create a pathway for them to do so. The second study here, the Posabon study, is just a recent document that brings together a lot of the research in this space. One of the things that we're doing at Patients for Patient Safety is a project that we're calling Pivot. It is really bringing patients, very, very diverse patient groups together to query from them, what is it that you would report if you were given the opportunity to do so? And we're looking at how to do this systemically through the use of HCAP surveys or other surveys of patients that we can deploy systemically. I do want to thank Johns Hopkins too, because they've been a partner in this space. We launched this project here in September of last year in this beautiful facility. They gave us their facility, they gave us their expertise and many other in-kind resources. We haven't thanked you enough, Johns Hopkins, so thank you very much for giving us this space and contributing and being a partner the way you have. And since that time, we've been sort of a traveling show looking at places where we can talk to researchers, talk to people from healthcare organizations, and say, what would be most helpful to you in your work in learning from patients? What things would be most helpful for you to improve care and improve outcomes? This is preliminary data. This project goes through September in the first phase. But this is some of the things that we're hearing from them. They're certainly willing to report harm. They report being dismissed, ignored, or disbelieved. And think about how that could contribute to diagnostic delay or misdiagnosis. They report bias, which again I think can be a contributor to delayed diagnosis or misdiagnosis. They report delays in diagnosis due to insurance authorizations. This is the kind of data that we're not capturing in any other source. We're capturing this because we go to patients and we can. So there's better ways in which we can use our surveys with patients and families to get them to report the things they want to report anyway. And they also report continuity of care breakdowns, a lot of which have to do with diagnosis and systems. We're doing a little lunch and learn session around Project Pivot. Please join us if you can at lunch, because we're going to be asking you what would be most useful to you in our work. I mentioned that we do advocacy. That's our third bucket. It might be one of the reasons why WHO hasn't published the framework we gave them, because I think they're a little nervous about this. But we are calling upon everyone that we talk to see the harm. If we can't see the harm, we can't fix it. We'll see the harm better if you include patients and families as reporters. When we see the harm, we can develop the research questions that we need to develop, the interventions we can develop, and out of that will also come a better picture of waste, which is a national priority. We are still paying for bad care, and that's wasteful dollars. And then we need to fix the loopholes in the law that don't align with with really prioritizing the way we want to. I do want to just mention, this is my last slide. I think I've gone over my 10 minutes. I apologize. But there's a patient safety structural measure that was implemented in the Medicare program last year. It has 25 questions that it asks hospital leaders to attest, are you doing this or are you not doing this in your organization? This is a reporting year. Next year it will be publicly reported. And this will give us the kind of data, the kind of information about all the variation that we see out there right now about how committed organizations are to really doing the kind of work that we think is important. So, oh my God, I didn't get the animation out of my slides. There we go. So there are things in here. There's a whole domain about system safety, asking you what programs do you have right now from a systems perspective that are helping you do this? There is open and honest communication. Are you doing it in your organization, and are you measuring its performance? These are not questions for the faint of heart, but you don't have to say yes, and there's no penalties for saying no. It's information gathering. It will fuel transparency that hopefully will incentivize more work in this space, and it will give people, I hope, in this audience, information you can use to ask the right research questions and engage and prioritize the right research questions. So with that, thank you very much for coming again. There's no time to lose. I think Carol made that point very, very carefully, very, very well today in a way that none of us could elsewhere. No one but Carol could do that, I think, on the panel today. And let's just move forward and get as much work done today as we can. Thank you. I went out of time, sorry.
Hello. Okay. So first of all, thank you to Doris Duke and Patients for Patient Safety, and to the Hopkins and Laura who made this happen. I know that everybody worked very hard, even until the like almost midnight yesterday. So thank you so much for that. And thank you for emailing in the middle of the night back. So, so now we have heard the problems. We still have patient safety problems. Now comes, how are we gonna solve these? What kind of approaches we can use? Engineers, I'm an industrial systems engineer and human factors engineer. So how are we gonna use engineering approaches, human-centered engineering approaches to re-engineer work systems? These are care work systems, okay? So, and I am talking about safe care, high quality, equity, accessible, and value-based care also. So all these can be achieved. I'm not suggesting that it is easy, but all these can be achieved with, or improved, let's say, by better systems design. So this is just to make sure we are on the same page. When we talk about today as a system, I am talking about a socio-technical work system, which means there is a social people, patients, physicians component, and also technical component. Technical doesn't only mean tools, technologies, and AI, which is part of it, but it also means culture of the organization, the physical environment, layout, the tasks, the nature of tasks that we give to, we assign to our professionals. And all of that design in the work system, the structured part, interact in some nonlinear ways. So this is why these are complex work systems, that nothing is really linear. And that is why we have expertise and a set of tools and methods to really study these work systems. It can be an ICU work system, it can be an OR, but it can also be more and more a home care work system, patient work system. So I go to people's homes, not to have coffee, but to study what kind of healthcare work system is established in their home environment. And all of that, how these are designed, interact in expected, unexpected ways. And then there's an external environment, like COVID happens, everything changes type of thing. So we are not immune to what is going on in the system. And all of that together affect processes and outcomes. As engineers, we start with actually look at the processes. And by processes, I mean the doing a surgery, those types of things, professional work, but also patient work and collaborative professional patient work. These are for us type of work. So we study work, we study processes to achieve, to redesign work systems to improve outcomes. The system has multiple goals at the same time: quality, safety, patient-centeredness, access, value. So it is really complex. So you need to make sure that you are not really making one goal, go in a terrible direction while you are trying to improve the other goal, etc. Systems design is not about, it's not about doing one design thinking session and thinking that you included your patients in that one session. Systems design is not about looking at what happened in your root cause analysis and find one root cause. Most of the time, there is much more than one root cause that caused some of those events. So there is really a science behind all of this. So in my work in the Human Factors Center within Armstrong, we really look at the entire care continuum. We look at actually multiple work systems, including, in the right, you can see real homes. These are real homes I went that you can see the patient, the medications, etc. And now we are going to, EMS. We are in the back of the ambulances, actually, trying to see how they are getting transition from home to ED. The reason why I'm showing that is, let me first, sorry. The reason why I am showing that is system of systems concept. We shouldn't, it is one thing to think about how we design a system, but we need to be actually looking, because we are allowed to talk about future today, which is one of my favorite things. We need to look at how to design systems across the service lines. When a patient goes to ED, then what happens to that patient? How do we support that patient's journey, etc.? So to be able to do that, we need to look beyond just our silos. Oh, what happens in the ICU? What happens in the OR, etc. So that is what I mean by system of systems. And we need to really, and with all the new technology, I think this is really a possibility, but we really need to intentionally design system of systems to support collaborative and distributed work. And distributed work by mean also distributed cognitive work. David mentioned those clinical judgments happen. Errors in clinical judgments happen. When we did some diagnostic safety work in the ED, we found that some of the problems or strategies are all associated with distributed cognitive work. It is a really joint cognitive activity going on there. We just don't see it. It is not tangible, but there is a patient, family, EMS, nurse, physician, etc., trying to make sense of all of that info to reach to a diagnosis. We actually have a subfield in our field called cognitive engineering that really focuses on how these clinical judgments are being made and how to design tools, technologies, and organizations to support cognitive work. So those are the things when I mean system science and system design. And the second part is resilience and adaptability. There will be no way we will develop a perfect system. And it is, again, it's an open system, right? Can be everything. So we also need to think about resilience and designing so that we can be resilient and we can have our frontline experts be able to adapt quickly. We shouldn't say, okay, technology will take care of everything. Experts are really important, and we are writing not paying enough attention to that. The frontline experts, including patient family experts, who know their child. Like I have worked with some work on children with medical complexity. Parents know those kids much more than clinicians. So that is what I mean, supporting expertise and using system design and technology to support that expertise. And what I wanted to also say here, the care transitions among these is very important to study. The care transitions are a process. It is not just giving info. It is so many other things, coordinating, physically traveling, making sure the medical devices, tools show up in your home on the day of discharge, all those things. So we really need to focus on, as things are getting more complicated and pushed to home, we need to really focus on how we are going to interact with home more and more, both to home and from home. I have been in Michigan, rural Michigan, watching EMS, trying to negotiate with patients. You know, let's go to this ED. You are not in good health. You need to go. Or trying to learn from nursing homes, what is this patient's status? Is this a DNR or not? These simple things are still big problems. On one hand, we are dealing with big AI things. On the other hand, we still cannot figure out if a patient is DNR or not in care transitions. Things this basic. So the way to study this is to actually go to people's homes, to nursing homes, to in the back of the ambulance traveling. Not because, I mean, I love the back of the ambulance that much. It's fun, but that is how you actually see what is happening. We went to 274 patients' homes. We first visited them in the hospital, in 2 different hospitals. We looked at how they were thinking they were gonna manage their medications when transferred home. And then we went to their homes. And you can read, because of time, and funding by AHRQ. I am so grateful to AHRQ. They started funding me with my dissertation grant many years ago. And here I am, so I'm truly grateful to AHRQ. And we have found many risk factors in the home. And it was like 95% of the time, there was a discrepancy in medications based on the discharge list versus the medications we saw. 2 farm techs went to each patient. I didn't go to each one, I shouldn't say. So what does that mean? So we need to be really smart, and not only smart, we need to really use the science. So developing just like checklists, the next interesting thing, EHR, etc., is not gonna solve unless we start looking at things as using system of systems type of thinking. What is on the horizon actually here? Artificial intelligence. What not to forget? System goals and patient families and professionals. We should be really careful about pushing technology to the system. The goal is not using the most fancy technology. The goal is actually improving the system and take care of patient family and clinicians. So same thing, because of time, I'm gonna skip, but again, another study funded by ARC, recently published. We identified multiple types or dimensions of expertise that goes to diagnostic safety, diagnostic work in EDs. How will AI one day, when helping us and helping today diagnose these conditions, how will AI needs to, or health IT needs to figure out these different types of expertise and needs to figure out how to support them. So we shouldn't design AI just like one condition and one prediction. it should fit to the workflow and it should make sense given the constraints, because our experts already know the organizational constraints in that setting. Otherwise, although this is more device-focused, although we will have many AIs in the wild soon and coming up, these are at least observable. You can see this mess. In AIs, we won't. That is another big danger. So we really need to understand how and the processes, our processes are not perfect either. So putting more technology is not gonna solve our broken processes. We need to be careful about that. And last slide, how can we evolve towards a true system of systems perspective? I'm not saying that we can do it tomorrow, but in everything we do, can we think of the big picture and then zoom into the micro improvements? How can we design and systems to better support teaming with patients and family caregivers across the care continuum? And how can we design AI-supported work systems? I'm not saying AI. I'm saying AI-supported work systems that are safe, equitable, and deliver, because our goal is to provide safe, equitable, high-value care, not to design the most interesting AI out in the world. Thank you.
Okay. Are you ready to work? All right, well, with these ideas in mind, and thank you so much to our scene setters, let's move into our working groups and begin the transition from inspiration to collaborative design. As a reminder, your colored dot indicates your assigned workshop room. Elevators to the ninth floor are just outside in the lobby. Please consider sitting with people who you have not met. We're counting on fresh perspectives and shared wisdom to shape today. The breakout groups are going to begin promptly at 10:30. Is there coffee now? There should be coffee upstairs, so I'm sure everybody's ready for that. So please make your way, again, promptly at 10:30. We will see you there.
And just one thing, there is a coat room up on the 9th floor where you can keep your luggage if you would like. And we will be concluding the day up there too, so it's fine to leave it there. No, reception. The reception will be up there. Sorry.